Hello, my name is Dr. Norman Lepore. I'm a clinical professor of medicine at the Geffen School of Medicine at the University of California, Los Angeles, attending cardiologist at the Smith-Cedars-Sinai Heart Institute, director of clinical research at Westside Medical Associates of Los Angeles, and the director of the National Heart Institute in Beverly Hills, California. We're going to talk about what I think is a very interesting topic that doesn't get covered very well during the course of the year in terms of lipid issues. We're going to talk about remnant lipoproteins, the rediscovered cardiovascular disease risk factor. Are we missing the target? These are my potential conflicts. So let's look for a moment just in terms of what the focus has been on in terms of publications and overall interest in the lipid field, starting back in the 1970s and taking this tour out into 2020. So what we see is that early on, there was really no interest in HDL, and then the HDL interest peaked around 2005, and now certainly because of the lack of effective treatments has really waned. The issues regarding LDL, you can see that they remained reasonably popular throughout, but certainly by virtue of all of the trials that we've seen, the Nobel Prize for the LDL receptor, that interest in the LDL in terms of being an important factor in atherosclerosis remains very high. And what's interesting, if you're looking at remnant triglycerides, you can see up to about 1990, there was a moderate amount of interest, then it really went down. And I think now we're starting to see an increase in interest in remnant triglyceride-rich lipoproteins, because I think we're now really realizing that they are really a key risk factor in addition to LDL cholesterol, perhaps even more important than LDL cholesterol in some patients. So let's look at some definitions of lipoproteins so we can make sure we're speaking in the same language. Non-HDL cholesterols really represent all those cholesterols which are not HDL. The remnants represent those molecules which really are the metabolic remnants of VLDL and chylomicron synthesis. So the remnants would be considered VLDL remnant, chylomicron remnant, as well as IDL. Whereas the non-HDL molecules include VLDL, the remnants, lipoprotein A, and LDL cholesterol. Now, what's interesting is size really matters. And one of the reasons why size really matters is because the very large molecules like chylomicrons cannot really pass from the blood into the endothelial cells where they can wreak havoc just by virtue of their size. However, the other molecules, because of their smaller size, can cross the vascular barrier and enter the arterial wall where it can be involved in the formation of plaque. So this is perhaps a prettier version of what we talked about. And we can see in terms of the density actually goes down as you go up on the y-axis, as well as the diameter going to the right. So what we can see is the proatherogenic lipoproteins, as we talked about, the smallest being lipoprotein A, the largest being the chylomicron remnant. And of course, we have the anti-atherogenic lipoproteins, the HDL molecules, which are also quite small and dense. So this, I think, is a nice pictorial color view of what we're talking about in terms of the ranges in size and density. Then let's look at the apolipoproteins, because these are the structural proteins which really kind of, in a way, define the actual structure and help identify how these lipoproteins are metabolized. So we know that ApoA1 is the primary source of lipoprotein that's associated with HDL. We know that the second arrow, ApoB48, is present in chylomicrons and actually distinguishes chylomicrons from the lipoproteins which are synthesized by the liver, which have ApoB100, and those include VLDL, IDL, LDL, and lipoprotein A. ApoC2 is commonly found on the chylomicron, VLDL, and HDL, and it's actually a cofactor for lipoprotein lipase. We're going to talk a lot about lipoprotein lipase because it's very much important in terms of the catabolism of these atherogenic molecules. So the fact that it's a cofactor for lipoprotein lipase is a good thing, whereas ApoC3, which is also present in chylomicrons, VL, and HDL, inhibits lipoprotein and therefore has deleterious effects in terms of the metabolism of the lipoproteins. ApoA3 is present on chylomicron remnants, IDL and HDL, and it's actually the ligand for the LDL receptor, allowing for its uptake into the liver and its eventual catabolism. So why should we care about triglyceride-rich lipoproteins and remnant particles? First off, they really represent a source of residual coronary vascular risk in patients with LDLs less than 70 milligrams per deciliter. So when you have a patient who you still see progression of disease either by imaging or by events with LDLs that are less than 70 milligrams per deciliter, really think about those lipoprotein-rich, those triglyceride-rich lipoproteins and remnant particles. And as we mentioned, the triglyceride-rich lipoproteins, or what we call TGLs, include chylomicrons and VLDL. And also the remnant lipoproteins are also triglyceride-rich, and those would be, as we mentioned, chylomicron remnants, VLDL remnants, and intermediate density lipoprotein, or IDL cholesterol. So why should we care about triglyceride-rich lipoproteins remnants? Why should we care? So this is really a pictorial cartoon of the whole process of lipoprotein metabolism. We know from the intestine and dietary intake, we have the formation of the chylomicron by virtue of lipoprotein lipase. You develop the chylomicron remnant, and we talked about the chylomicron remnant being small enough to get through the to get into the endothelial wall where it can wreak its havoc. Whereas in terms of the liver really is the primary source of VLDL, and we know that VLDL is catabolized again with the help of lipoprotein lipase to the IDL molecule, which is further catabolized to LDL. And under circumstances that we'll talk about in a little bit, the development of small dense LDL, which has a particular proclivity to cross into the vascular cells, the endothelial cells, and lead to atherosclerosis. And so here we have insulin, by virtue of its effects on free fatty acid metabolism, actually leading to the uptake as an energy source of free fatty acids in the muscle, the adipose tissue, and uptake in the liver. And under the influence of the components in the liver, you can actually develop, when you combine ApoB100 and other components, the actual synthesis of VLDL cholesterol. And these components actually get into the endothelial cell, and you can see they lead to activation of monocytes, increases in oxidative state, free radical formation, cytokine storm, and this leads altogether to the development of plaque and ultimately to plaque rupture, which leads to coronary and vascular events. This is another cartoon depicting an overview of ApoB metabolism. Remember, it's ApoB100 is involved in the synthesis of lipids in the originate in the liver, whereas in the chylomicron, it's the ApoB48. And what we can see here, the free fatty acids, by virtue of the effect of insulin, get into the hepatocyte, combining it with ApoB100 and a process that involves the lipidation. You actually have the main product in the liver being VLDL cholesterol. And VLDL cholesterol, as we talked about, by virtue of the action of lipoprotein lipase, actually leads to the development of IDL as well as the VLDL remnants. And we talked about how these are particularly pro-atherogenic molecules. VLDL goes to IDL, which is then catabolized to LDL cholesterol, where it's then picked up by the LDL receptor. Interestingly enough, the VLDL remnants are also picked up by the VLDL receptor, as well as other non-LDL receptors on the surface of the hepatocyte. We're going to talk a little bit about the cholesterol ester transfer protein, CETP, as it's normally called, actually leads to the transfer of cholesterol esters from the HDL molecule to triglyceride-rich lipoproteins and LDL cholesterol. And in addition, what it also leads to is the movement of triglycerides from the triglyceride-rich lipoproteins to LDL cholesterol and HDL cholesterol. So CETP is very much involved in the catabolism of lipoproteins. And as we'll show you here, we know in clinical situations, elevated triglyceride levels are associated with the small, dense LDL molecule. But let's see how that happens. And a lot of it is related to the cholesterol ester transport protein. So under normal triglyceride situations, the major movement of lipids is cholesterol ester from HDL into the LDL molecule. So that's the main movement by virtue of the CETP protein. You do have some movement of cholesterol ester to the triglyceride-rich particles, and you do have movement of triglyceride from the triglyceride-rich lipid pool to the LDL pool as well in LDL, the LDL molecule. Now, what's interesting under situations where you have elevated levels of triglycerides, so you can see compared to the normal triglyceride, the actual size of the pool of the triglyceride-rich lipoproteins is larger. But what you have is you have a conversion. So rather than seeing a lot of the cholesterol ester being transferred from the HDL to LDL, what we're seeing is more of a transfer of cholesterol ester from HDL to the triglyceride-rich pool, more triglyceride being transferred from the triglyceride-rich lipids to HDL, and triglyceride to the LDL pool. And eventually, this leads to the development of the small, dense LDL molecule, which we know is much more atherogenic than its larger, more buoyant cousins. And again, this is what happens in the milieu of hypertriglyceridemia. This is just another depiction of the difference when we have optimal plasma triglycerides, that's less than 1.2 millimoles per liter, which is about 100 milligrams per deciliter, versus those patients who have moderate to severe elevated plasma triglycerides. What you have here, you can see that you have a larger number of VLDL molecules. They're overproduced by virtue of this elevated triglyceride level. You get a shift in terms of the movement of fats. So you're getting a greater amount of the transfer of triglyceride-rich components to the IDL and to the remnant proteins, with actually less of it actually being transferred to the LDL pool. And with that, you're getting greater amounts of the atherogenic particles, IDL, VLDL remnants, which actually hang around the circulation a lot longer. And therefore, they're able to, by virtue of their atherogenic potential and the fact that they're not removed from the circulation in rapid fashion, are actually allowed to perform their atherogenic deeds. So under this condition of elevated triglycerides, we talked about the effect in terms of the cholesterol ester transport protein. And by virtue of this, you end up with a very atherogenic milieu with increased small, dense LDL molecules, as well as larger amounts of the remnant lipoproteins. So in this slide, what we see are really the activators of lipoprotein lipase. Lipoprotein lipase, as we've talked about, plays a very important role in terms of the catabolism of VLDL and the chylomicrons, and their eventual catabolism, for instance, to LDL, with a consequence removal from the liver by the LDL receptor, as well as inhibitors of lipoprotein lipase, angiopoietin protein like 3, like 4, ApoC3, which actually have an inhibitory effect of lipoprotein lipase, and therefore lead to increases in terms of these remnant lipoproteins. So let's look at the risk of atherosclerotic coronary vascular disease events and non-fasting triglyceride levels. Generally in clinic, we try to measure, just because of consistency, fasting triglycerides. But actually, as I'll show you in subsequent slides, we actually exist in a situation where there are greater levels of triglyceride in our circulation, and therefore the non-fasting triglyceride level may not be the best way to measure the atherogenic potential of the triglyceride-rich lipoproteins. But anyway, what we can see, looking at non-fasting triglyceride levels, there's certainly a significant effect on these elevations of the triglyceride levels, non-fasting, on myocardial infarction as your levels go up, on the ischemic stroke incidence, and even in terms of aortic stenosis. So what we see here is the relationship between ASCVD events and non-fasting triglyceride levels. So there are different definitions for what would be considered optimal, normal, and borderline high, high, and very high triglycerides. I think what we can all agree is that a optimal triglyceride level would be less than 100 milligrams per deciliter or less than 1.13 millimoles per liter. Whereas a borderline high level would be something that perhaps many of us would not consider particularly harmful, triglyceride levels between 150 and 199 milligrams per deciliter versus 1.7 to 2.3 millimoles per liter. And very high levels, I think we can all agree on, would be those patients who have triglyceride levels greater than or equal to 500 milligrams per deciliter. So I think part of our change in our approach to triglyceride is realizing that if we really want to optimize triglyceride levels, we really want to be able to achieve levels below 100 milligrams per deciliter. And I think this is depicted from the 2021 consensus statement from the European Atherosclerosis Society in terms of definitions of normo and hypertriglyceridemia, where optimal levels were less than 100 milligrams per deciliter, and obviously severe and extreme above 500 and 880 milligrams per deciliter. This really, I think, depicts from the Eric and Framingham offspring studies the fact that triglyceride levels actually are related to an increased risk of cardiovascular events at levels way below what we would consider to be atherogenic. We can see even having levels going from a level of approximately 50 to 100 milligrams per deciliter, we're still seeing an increase in risk. And really, after you get to a level about 200 milligrams per deciliter, we actually see it plateau. So therefore, this may be an area in terms of triglyceride levels that we're going to need to focus on more, just like with LDL cholesterol. With time, consensus and guidelines became more aggressive and lowered thresholds for LDL treatment. We may also see that with triglyceride treatment, particularly in patients where we've already optimized their LDL levels and there's evidence of further progression of atherosclerotic disease. So let's look at the role of triglyceride-rich lipoproteins in atherogenesis. Remember, we talked about the chylomicron remnant, the VLDL remnant. We talked about the intermediate density lipoprotein, the fact that just by virtue of size, they can actually get into the intima of the blood vessel and yield, by virtue of their inflammatory effects and other effects, the development of the foam cell, and with continued recruitment of these remnants, we get further inflammation, release of pro-inflammatory products, the formation of fatty streaks, the formation of actual plaque, leading again, playing again the role of triglyceride lipoproteins in atherogenesis. Remember, we really haven't talked about LDL much. Really, what we're really talking about are these very atherogenic remnant lipoproteins. So remnant-like particles are elevated, and actually most states have elevated atherosclerotic coronary vascular disease risk. It's higher in men and women. It's higher in older than in younger subjects. It's higher in postmenopausal than in premenopausal women. It's higher postprandially. We see it higher in patients who are obese, in patients who have impaired glucose tolerance and diabetes mellitus. Of great importance, we actually see it in patients with end-stage renal disease and those who are on hemodialysis. Oftentimes, these patients have levels of LDL cholesterol that are actually quite normal, where the focus may be perhaps needing to be changed in this patient population to actually focusing on the remnant-like particles. It's also seen in patients who have atherosclerosis. Now, what's important about the non-fasting state? Well, the non-fasting state is the state that we're in most of the day. Most individuals are actually in a postprandial state, ingesting several fat-rich meals during the day. Plasma triglyceride levels peak after bedtime, and the nadir is in the early morning after an overnight fast. In a real-world setting, random non-fasting postprandial triglyceride is on the average of 20 to 25% higher than fasting values. However, we can see that percent even higher in patients who have elevated fasting triglyceride levels. We know that fasting triglyceride level is strongly predictive of a triglyceride response after eating. Also, population and genetic studies have identified non-fasting or postprandial hypertriglyceridemia occurring 8 hours or more after a meal as an important but neglected risk factor for premature atherosclerotic coronary vascular disease. This really goes against what has become habit for us when we tell our patients to come in a fasting state. Perhaps we are underestimating the impact of remnants and triglyceride-rich lipoproteins, and we may be missing it by focusing on the fasting level of triglyceride. So as mentioned before, the large triglyceride-rich lipoproteins are not atherogenic like chylomicrons, in contrast to the cholesterol-rich remnants that are formed after removal of triglyceride from these triglyceride-rich lipoproteins by lipoprotein lipase-mediated lipolysis. So as mentioned, a very large molecule like chylomicron is too big to actually cross into the blood vessel wall, which leads it to not being a particularly atherogenic molecule. Clinical recognition of postprandial hypertriglyceridemia is hampered by technical difficulties and the lack of an established clinical protocol for its characterization. So, when do we? How big of a meal? How long after a meal? What kind of meal do we actually measure to get some standardization of a postprandial hypertriglyceridemia? Obviously, there's consistency. We have patients come in fasting, but it's certainly you lose consistency if you're assessing in the postprandial state. And we know that the triglyceride-rich lipoproteins and their remnants are implicated in plaque rupture and thrombus formation via redox-sensitive mechanisms, tissue factor secretion from the endothelium, and stimulation of monocytes and thrombin generation. So, and since we're existing more of the time in these non-fasting states than we are in a fasting state, I think this increases the implications and the effect of these triglyceride-rich lipoproteins, which are more difficult to remove from the circulation, and they are at higher levels because we're more often in a non-fasting state than a fasting state. So what we also know is that acute elevation of triglyceride-rich lipoproteins and the remnants in the postprandial phase induce a bunch of bad things. Impaired vasodilatation, upregulates the production of pro-inflammatory cytokines, enhances an endothelial inflammatory response, and upregulates expression of vascular cell adhesion molecule 1 and monocyte activation. Lipolytically reduced saturated fatty acids and phospholipids contain oxidized fatty acids. They activate toll-like receptors of subendothelial macrophages, leading to the production of reactive oxygen species and pro-inflammatory lipids and proteins. And triglyceride-rich lipoproteins are also associated with activation of the NLRP inflammasome in human monocytes, which is really an amplifier of inflammation and the inflammatory process. So let's look at a relationship between remnant cholesterol and plaque volume. So what we can see is as on treatment remnant cholesterol levels go up, so does the difference in plaque volume. So a relationship between increases of these remnant cholesterols versus plaque volume seems to be a reality. What's interesting in diabetics, this really plays a big role, the increase in these remnant lipoproteins. And what we can see here, looking at the cumulative event-free probability, that the probability is a lot lower, talking about event-free probability in diabetic patients who have elevations of remnant lipoproteins above 4.7 milligrams per deciliter versus those who have lower levels. So the presence in the diabetic, for instance, of these remnant lipoproteins is associated with a greater likelihood of a cardiovascular event. Now, what's interesting, and this may be related to the fact that there are syndromes more common in younger people where they have elevated levels of remnant cholesterols, it seems that the remnant cholesterol levels actually have a greater effect in terms of events like overall cardiovascular disease or stroke and myocardial infarction. In the red, you can see, looking at the hazard ratio versus the levels of these remnant cholesterols, that if you're over 40 years of age, it doesn't seem to be a very strong relationship until you get to higher levels of these remnant cholesterol lipoproteins, whereas at lower levels in younger people between 18 and 39, you actually see a much more potent relationship between these remnant cholesterols and the risk of cardiovascular disease. And again, that may be related to the fact that we're seeing perhaps mutations and other issues that may be playing a role in that younger population. Now, we actually can do a pretty good job of estimating remnant cholesterol levels with the kind of information that we get from a lipid profile. So remember that the remnant cholesterol is the cholesterol content of all non-LDL and non-HDL lipoproteins. So basically, you're estimating from a standard lipid profile, you take the total cholesterol minus the LDL cholesterol minus the high density lipoprotein cholesterol, and that gives you the remnant cholesterol level. And we can see that a level greater than 24 milligrams per deciliter is actually associated with ASCVD. So I think it should be perhaps a routine for us not only to certainly assess LDL cholesterol and in patients with elevated triglycerides, non-HDL cholesterols in particular, but also having this measure of the remnant cholesterol. There are other assays that are actually in development so that we can even have a more precise approach to measuring these remnant cholesterols using ultracentrifugation, lipid chromatography, and immunoseparation, and NMR, but we're not quite there. And these, in terms of clinical utility, and these are quite cumbersome. Approaches. So now that we've talked about the remnants and triglyceride-rich lipoproteins, let's look at some of the treatments that we've tried to deploy to actually have an impact. Let's go ahead and we'll talk about the omega-3 fish oil story. First of all, we know, and certainly here in the United States, there's a lot of consumption of fish oils because people are being told that it can improve their cardiovascular health. Most of the consumption is actually the kinds of preparations that you get at health food stores or supermarkets, which in my mind aren't particularly useful. First off, because you have no idea about the approach used to manufacture these items. These items often will be stored for long periods of time in not particularly optimal conditions, leading to actual oxidation of fatty acids. But let's look at omega-3 oils as a whole. First of all, there's DHA and EPA. Well, they both have in common the ability to reduce fasting or postprandial triglyceride levels. And the major mechanism of reducing serum triglyceride is associated with a decrease in terms of the number and size of VLDL particles. The VLDL reduction results in a faster conversion of VLDL particles to IDL and then to LDL cholesterol. But the problem is there's big differences between the DHA and EPA cholesterol. So they're not equal in terms of their potential anti-atherogenic effects. First off, what we can see is one of the two effects that EPA has that it don't occur with DHA is that EPA actually displaces arachidonic acid from the endothelial cell. It inhibits lipid oxidation, and it actually inhibits the development of cholesterol crystalline domains within the blood vessel wall. It also has much more potent antioxidant activity and inhibits, as mentioned, the crystalline domains under atherogenic conditions than the DHA molecule will. So when you say I'm taking omega-3s, there's obviously a big difference between EPA and DHA in terms of their potential anti-atherogenic effect. And this slide actually, I think, goes into a lot of detail in terms of what effect EPA has, icosapentaenoic has, in terms of increasing versus decreasing. And what we can see is that most of these effects lead to a reduction of oxidative stress, lead to a potential reduction in terms of the development of unstable plaque, increased nitric oxide bioavailability, vasodilatation, free radical scavenging, less oxidative LDL, less adhesion of monocytes, et cetera. So you can see that there are a lot of atheroprotective effects of EPA that do not seem to be in common with DHA. So let's look at this particular regression plot. This is looking at non-HDL cholesterol and major cardiovascular events. And you can see here that we've included trials in this meta-analysis, statins, fibrates, niacin, et cetera. And what we can see is there's a nice regression where 1 millimole per liter decrease in non-HDL cholesterol. So remember, non-HDL cholesterol would be all those atherogenic components, actually leads to a 21% reduction of cardiovascular events. But as you can see in this particular plot, most of the effect in terms of the reduction of cardiovascular events were in those trials that assessed the efficacy of statins. So it really seems that for the most part, statins really are really the powerhouse in terms of the implications of a non-HDL relationship with major cardiovascular events. Now, on this particular slide on the top, we're going to now look at the implications of triglyceride levels. So if you look at all these same slides, and again, we're including the slides that include the studies that include statins, fibrates, niacin, and omega-3 fatty acids, what we see is that a millimole per liter decrease in triglyceride led to a 16% cardiovascular event reduction with a p-value of 0.0026. However, that's if you include the REDUCE-IT trial, which was a trial with EPA. If you exclude the REDUCE-IT trial, you actually find a non-significant relationship between triglyceride levels and major cardiovascular events. Whereas if you look at the differences in LDL cholesterol in the lower part of the slide, you still see that this 1 millimole per liter decrease in LDL cholesterol gives you about 20% event reduction, which is pretty classic thinking. So what we're seeing here is in the world of triglyceride intervention trials, aside from the REDUCE-IT trial, we do not seem to be getting a very good bang for our dollar in terms of the implications and the effect of reducing triglycerides, except with the use of EPA in the REDUCE-IT trial. So this is looking at the regression plot of omega-3 fatty acid doses and major cardiovascular events. And here we're actually separating the effect of EPA versus the effect of DHA. And what we do find is there actually is a relationship in terms of reduction of cardiovascular events by increasing EPA doses, going from 0, 1 to 3 and 4 grams per day. So a relative risk reduction of 7% occurred per 1 gram of EPA ingested with a satisfactory p-value. Whereas looking at DHA, we see a non-significant relationship between DHA dose and a reduction of cardiovascular events. So let's look at the recent cardiovascular outcome trials with omega-3 fatty acids. The JELIS trial, REDUCE-IT trial were both with EPA. The STRENGTH trial that we're going to talk about that was recently presented at the American Heart Association actually used a EPA-DHA combination. Let's look at some of the baseline. What we can see is that in terms of the trial, JELIS, which was actually performed in Japan, high baseline EPA levels, they eat lots of fish. Whereas similar baseline levels of EPA between the REDUCE-IT trial with EPA versus the STRENGTH trial with the combination of EPA and DHA. We can see that they all led to increases in achieved EPA levels from their baseline levels, and you had significant triglyceride reduction in all these trials. Now, what's interesting, as mentioned, the REDUCE-IT trial, you had your 25% risk reduction of cardiovascular events with a p-value of 0.00000001. Whereas the STRENGTH trial, there was no significant reduction in terms of cardiovascular events. We did see event reduction in the JELIS trial, which was an open label trial that was held in Japan. Now, if we look at the REDUCE-IT trial, remember the REDUCE-IT trial was an EPA trial, patients who had diabetes or had cardiovascular disease. They were actually optimally treated, and they were randomized to EPA versus placebo. And what we see here in terms of EPA levels, that there is a reduction between EPA levels and the rates of cardiovascular events. And that occurs with achieving levels to as high as 400 microgram per cc. So for the primary endpoint, the greater the average EPA serum level. For the secondary endpoint, as well as for cardiovascular mortality, there did seem to be a relationship between EPA serum levels and prevention of these events. The RESPECT EPA trial was also just presented at the American Heart Association. It was an open label randomized trial in patients with chronic CAD who were on statin therapy. And they also had to have an EPA to arachidonic acid ratio of less than 0.4. Over 2,500 patients, they received about 1.8 grams of EPA. Enrollment was about 4 years. Follow-up period was 4 years from the end of the enrollment period. Now, the primary endpoint, there was a strong trend towards a reduction. That was a composite of CV death, non-fatal MI, non-fatal stroke, unstable angina, or revascularization. There was a reduction, you can see, of approximately 22%. The p-value was 0.0547, so it missed statistical significance. But the secondary endpoint included composite events of coronary artery disease, composite events of stroke, and events related to death, where we did see a significant reduction of that secondary endpoint of about 26% with a p-value of 0.030. So what we're starting to see is a rather consistent message that EPA actually is the way to go in terms of impacting triglycerides and impacting cardiovascular events. The Achilles heel is we did see an increase in terms of GI disorders, and there did seem to be an increase in atrial fibrillation versus placebo. So in the STRENGTH trial, what's interesting is even if you look at the patients in terms of the top tertiles of EPA levels achieved versus DHA, even those patients that had the highest levels of EPA in the STRENGTH trial, you did not see event reduction. And so some people speculate that, there may be something actually about the presence of DHA, which will dilute or it will negate the potential benefit. So when you're giving patients these combinations of DHA and EPA, you actually may be blocking the potential beneficial effect of EPA. That's only conjecture. But what we see from this trial, which deployed Epanova, which had EPA and DHA, we did not see a reduction of cardiovascular events. So let's switch gears now to the fibric acid derivatives. So they actually have a lot of very positive characteristics. PPAR alpha increases the activity of lipoprotein lipase, which we've mentioned is a very positive thing, leading to the more active catabolism and eventual riddance of triglyceride-rich lipoproteins, reduces hepatic VLDL cholesterol, reduces ApoB levels and triglyceride production. It increases the lipolysis of triglycerides in VLDL cholesterol and chylomicrons, again, through the activation of our friend lipoprotein lipase in the capillary circulation of adipose tissue and muscle, through the inhibition of the secretion of ApoC3. And we're going to get back to ApoC3 in a minute. ApoC3 being a inhibitor of lipoprotein lipase, as well as increased secretion of apoprotein AV, which decreases triglycerides by inhibiting VLDL production. So here are some of the effects in the prominent trial, which was pemafibrate, which is a potent PPAR alpha modulator. And what we can see is it does a lot of the nice things biochemically that we'd like to see. You saw a reduction of 31% versus placebo 7% with triglycerides. VLDL cholesterol dropped 35% versus 10%. Remnant cholesterol levels dropped 31% versus 15%. And we actually see ApoC3 levels actually went down. Remember, we talked about ApoC3 being an inhibitor of lipoprotein and not a good particular characteristic to have in your patients with triglyceride issues, went down greater in the group on pemafibrate than placebo. But no real change in total cholesterol, a mild change in terms of HDL, 8.3% decrease with pemafibrate versus 3.1% increase in placebo. But interesting, we did see about a 14% increase in LDL versus a 2.9% increase in LDL in placebo. And this may be the Achilles heel of the PPAR alphas, their increases in LDL levels. We did not see any change in non-HDL cholesterol levels. So net, there was really no change in terms of the ApoB 100 molecules. And of course, the primary outcome, the primary composite cardiovascular outcome showed there was actually no effect with pemafibrate versus placebo on cardiovascular outcomes, despite all those very positive effects that we saw chemically with remnants and triglycerides, although we did see that increase in LDL cholesterol. What are the lessons from Prominent? First, there's an increased efficiency in the conversion of triglyceride-rich lipoprotein remnants to LDL cholesterol rather than their removal by the liver. As we saw in the Prominent trial, this led to an increase in LDL cholesterol, which actually may counter perhaps some of the potential benefits of PPAR alpha. Pemafibrate-mediated reductions in triglyceride-rich lipoprotein remnants, which were accompanied by increases in LDL cholesterol and ApoB levels. So the lack of benefit suggests that beyond the effect on triglyceride-rich lipoproteins, remodeling, enhanced clearance of triglyceride-rich lipoprotein remnant particles from the circulation, rather than their conversion to LDL particles, may actually be the way to go in terms of impacting and leading to a positive cardiovascular event. So let's look to the future before we end the presentation. Emerging therapies to treat hypertriglyceridemia. And what we can see is we talked about therapies which have complex effects, the omega-3 fatty acids. In terms of LPL activation, we have in development ApoC3 antisense oligonucleotides, which lead to basically a silencing of the RNA that leads to the synthesis of ApoC3. And in our laboratory, we're actually involved with in clinical trials looking at approaches to actually silencing the production of ApoC3. There's an angiopoietin-like protein-like 3 inhibitor. There is certainly an antibody to angiopoietin protein-like 3 in commercial use, and this may also have value in terms of shunting the triglyceride-rich lipoproteins and allowing them to be picked up by both the LDL and non-LDL receptors on the liver surface. So this is looking into the future. Both ApoC3 and angiopoietin-like 3 both block lipoprotein lipase, so being able to mitigate the effects of ApoC3 and angiopoietin-like 3 would lead to more efficient removal of these remnants from the circulation. And again, here's this cartoon showing ApoC3 and the fact by virtue of its effect on hepatic lipases and lipoprotein lipase actually exerts its deleterious effect in terms of blocking the catabolism of these remnant molecules. And again, that's a focus that we're evaluating in clinical trials at Westside Medical Associates of Los Angeles. Other potential metabolic effects evaluating angiopoietin protein-like 3. Again, the key fact, it leads to a decrease in angiopoietin protein-like 3 leads to a decrease in lipoprotein lipase activity, decreases in endothelial lipase activity, and by blocking that particular protein, perhaps either by antibody or by cutting its production in the liver, would have positive effects in terms of increase in the uptake of VLDL and LDL particles by the liver. Let's talk about the consensus statement from the European Atherosclerosis Society in 2021. This is what they're saying, that the regulation of plasma levels of triglyceride-rich remnants and remnants is complex. Developing therapies that affect these particular characters, such as the remnants, and reducing ASCVD risk is challenging, as we can see from some of the omega-3 trials, as well as the trials looking at the PPAR alphas. Improved understanding of the pathways that determine circulating levels of triglyceride-rich lipoproteins and remnants is needed. A key question is whether targeting lipolysis and clearance of triglyceride-rich lipoproteins and remnants, rather than remnant production itself, is more effective for reducing ASCVD risk. For existing therapies, clinical trials that use validated specific assays essential to inform whether lowering levels of triglyceride and triglyceride-rich lipoproteins and or remnants can reduce ASCVD risk. So perhaps we need better assays to be more precise. And of course, we'd like to be able to determine the relative atherogenicity of triglyceride-rich lipoproteins and remnants versus LDL cholesterol. And this will, again, will require specific assays for these lipoprotein species. So what do we do now? Well, we can really have an effect in terms of lifestyle. Dietary goals should include avoiding highly refined carbohydrate foods, incorporating seafood, particularly fatty fish, increasing fiber-rich foods such as fruit, vegetables, and whole grains, avoiding excess alcohol, substituting mono and polyunsaturated fat, mostly from plant oils and nuts, for animal fat, such as meat and dairy. Dietary trans fatty acids increase triglyceride levels minimally, but should be avoided because they actually significantly raise LDL cholesterol and lower HDL. And certainly energy intake should be adjusted to achieve and maintain an ideal body weight. So are you confused yet? Oh my God. Neutral findings with pemafibrate are consistent with outcomes in other trials evaluating PPAR alphas as well as niacin, the AIM-HIGH trial and others, so that we're not able really to see a consistency in terms of the reductions of these metabolic catabolites like these remnants and triglyceride-rich lipoproteins. Maybe we're just not attacking it in the right way. However, we also see consistent with these of the reduction of cardiovascular events with icosapent ethyl intervention, the REDUCE trial of icosapent ethyl, in which the observed risk reductions in triglyceride levels were actually not related to the reductions of cardiovascular risk. So what was interesting is the reduction of triglyceride, which occurred with EPA, was actually not related to the cardiovascular event reduction. So perhaps it's not the level, but it's perhaps what it does within the vessel wall. So with that, I hope I was able to provide you some enhanced understanding of the importance of triglyceride-rich lipoproteins and remnant particles, talked about the importance of considering non-fasting levels of triglycerides in order to even perhaps better assess cardiovascular risk. And I hope you were able to get some clinical pearls from this presentation that will help in your own practice. Thank you very much.